Okay, I think we're going to get started, everybody. Firstly, I want to give a warm welcome to everybody. Thank you very much for coming today. Okay, it's great to see so many people in attendance for the first Epilepsy Education Day we've had in this area in quite some time. Alright, for those who don't know me, my name is Beck and I'm the practice manager for Dr. Gordon here in Orange. Okay, I had childhood epilepsy myself, which is why I'm passionate about putting this day on and getting as much information, education and awareness of epilepsy into the community. At the moment, I am working on getting an epilepsy support group organised for the area. So in saying that, we do have an epilepsy support group page on Facebook where you can go and like that to keep up to date with the progress of where we're at with that support group. Okay. You've all been handed a survey. If we could have them filled out and handed back at the end of the day. On the bottom of that, there is a part where you can put your details, your name, postal address or email, if you don't have access to Facebook and want to be involved in the support group and be kept up to date with its progress. Today, the whole event's been sponsored by UCB Pharma, so without their sponsorship, today would not have been possible. It was very generous and can't thank them enough. I'd also like to thank all the speakers that are here today for their time, their valuable knowledge with what they'll be sharing with us today. Now, toilets are out here over to the left of me, if anyone needs those. If everyone could have their mobile phone, please switched on to silent or off before we get the first speaker up. Today the session is being recorded so that we can use that for educational purposes. Okay. Alright, so let's get started. I'd like to introduce our first speaker today, who is Claire Ward. Claire is an accredited practicing dietitian. She has worked as a dietitian for 16 years in a variety of clinical areas over the UK, Sydney and the Central West. She currently sees private patients at the Cullen City Medical Practice, and she also works part-time at the New South Wales Local Health District. Let's welcome Claire.
Hello everyone, thank you Beth for that lovely introduction. So today I'll be talking to you about nutrition and diets for people with epilepsy. Has anyone ever used a ketogenic diet? Is anyone familiar with it? No. I thought there might have been some hands. No? Yep, one? Yeah? Yep. What's that, sorry? Yes, that's right. Yep, so you've had a go. Did you have success with it? Oh, yep, have you had a go at it? Yes, yep, excellent, yeah. So it's one of those diets that, some people have used it and some people haven't, and a lot of people just aren't really aware of what it actually is involved in it. But it was developed in the 1920s, so it's been around for a little while, and it was used to reduce anticonvulsants, improve mood, behaviour and cognition for people with epilepsy. Basically, yes, it's a high-fat diet, as you said. It's a very low carbohydrate diet, and it also has an adequate protein for growth. So it mimics the effects of fasting. The calories are often restricted to just a bit below the requirements, about 85 to 90%. And obviously there's a lot of nutrients that aren't met as well. So multivitamins, minerals, calcium supplementation is also required. The ratio of the fat to carbohydrate is about 4 fat to about 1 carbohydrate. This is the most extreme, I suppose, of the ketogenic diets. But there is some that are 3 to 1 and 2 to 1 as well. But the traditional one is 4 to 1. So this is a little picture for you to show you just a brief summary about, we call it the ketogenic diet food pyramid. So are you familiar with what the normal pyramid looks like? It's pretty much upside down. So as you can see, the fats and the oils are right down the bottom. And as you know, in our normal diet pyramid, they're in the top. Then we've got our meat and protein sort of foods, cheese and eggs, the salads and veggies, and the fruits. So normally we're told to eat lots of fruits and veggies for standard healthy eating, but on the ketogenic diet, it's actually the opposite. It's actually reduce your fruit and veggies and eat more fats. Okay? So this diet, it is a very difficult diet to do, a very difficult diet to maintain. Quality of life is, I suppose it's not nice, you can't have a glass of wine, and you can't have chocolate, and all the things that we generally like to eat and drink. So it is a very difficult diet to follow. It does need full supervision. It's not something you can just go out and just give it a go. Traditionally, it's implemented in a hospital setting when we're doing the extreme version, the 4-to-1, because you require like a specialised team, including a dietitian and doctors and nurses, to be checking bloods and ketone levels and urine daily. And generally, we get you to fast for 24 to 48 hours prior even starting the diet. So it does require regular reviews, and especially for children who are growing, who their needs change every year, they need to be assessed annually on top of that as well. So people always ask, how does a ketogenic diet work? What makes it successful? Well, the mechanism of action, there's been a few hypotheses that are out there. At the end of the day, they do think it's a combination of them all. But there's a pH hypothesis where you're looking at the ketogenic diet makes the blood and then presumably the brain more acidic. And this mild acidosis is an anticonvulsant. Then we've got the metabolic hypothesis. This is when the ketogenic diet makes the brain switch from a glucose-based metabolism to a ketone-based metabolism. And this change produces the anticonvulsant effects. The fat that provides more energy, or a different type of energy, to the brain, and this lack of energy leads to the anticonvulsants. Then we have the amino acid hypothesis. This is where the ketogenic diet modifies the balance of the amino acids transmitted in the brain in such a way to suppress the seizure activity. And then we have the ketone hypothesis, and this is when the ketone bodies themselves have a direct anticonvulsant effect on the brain. The acetone hypothesis suggests that it is an increase in the brain and the blood and the brain levels of acetone that causes the anticonvulsant effects in the diet. I just need to go back to that picture. That picture one. Yep. This picture here is a really good summary, actually, to make it easy to understand of how the ketogenic diet works. And as I said, it's a combination of all those hypotheses. There's still a lot of research out there, ongoing, I suppose, trying to work out exactly why it works. But in foods, we have fats, carbohydrates, and proteins, and it's that balance of the fat versus the carbs and the protein that can actually help with the anticonvulsant. So the ratio of the food produces a source of energy called ketones. So your body's in what we call ketosis, where your body is using fat as its main source of energy rather than the carbohydrate, which is generally the preferred source of energy. And this fuels the cells in the heart and brain. The fueling the cells means that there's more brain energy, which protects the brain from future seizures. So that's just a nice little summary to help you understand just the basis of where it is. There's so much research out there. There's studies and studies and studies and studies. I've actually got one at the back left if anyone is interested in a bit more detail of a summary that was done in about 2009, which combined all the studies together, and it's a good overview of the diet and ketogenic diet and its seizure activity levels. So does it work is the question as well. Like, we go through these diets and they're quite restrictive and it's quite hard. And does it work is the question. So about 50% of the time, the studies are showing only about 50% of the time that it does work. And it can be a 15% chance of complete seizure-free as well. So the problem with a lot of the studies is that there's a lot of withdrawals. So people pull out of the studies because of the side effects of being on the diet. It is such a hard diet. So the studies, I suppose, we don't get big numbers, as you can imagine, so it's not conclusive at all. The question is, I suppose, is the side effects, does it outweigh the quality of life of being on a diet like this? And I suppose that's an individual, case-by-case sort of thing that you would discuss with your doctor, and obviously with the dietitian as well, who would guide you through it, but it is case-by-case. To give you some examples of some of the complications, there's the list of some of the complications that are commonly seen on people with this diet. Constipation is one of the most popular, purely because there is really no fibre in the diet. So because it is fat-based rather than carbohydrate-based. Vomiting, diarrhea, gallstones, renal stones, a lot of nutritional deficiencies, anorexia. So there's a lot of complications there. You don't always experience these complications, but there is obviously they're there, and that is one of the things to be aware of if you do go on that sort of diet. So a more popular diet, I suppose, used more these days, which was developed in 2003. So this one's a bit more relaxed, I suppose. It's not as strict as the 4-to-1. You don't need to, I suppose, fast for 24 to 48 hours either. You can start it more easily. It can be started in practice rather than have to be, hospitalised. It does still restrict carbohydrates. It restricts it to about 10 grams a day for children, about 20 grams a day for adults. So to give you an idea of what that actually is, like a piece of bread is equal to about 15 grams of carbohydrates. Okay, or a cup of milk is equal to about 15 grams of carbohydrates. So it's not much still. Do you know what I mean? So it's not, let's just go and eat it all. You still need that lower ratio. The fats are obviously still encouraged to maintain ketosis. The actual diet itself is about 70% fat, 25% protein, and 5% carbohydrates. Whereas the other ketogenic diet is 90% fat, only 7% protein, and 3% carbohydrate. So it's a big difference. It would affect your quality of life a lot. So the studies done on this one since then, there's been about 22 studies done on this one. Of that, 44%, so nearly half of them, did have less than 50% seizure reduction after 6 months. And of which 72 of them had 90% improvement. So they're kind of still seeing the same results with this one as they did with the really strict one as well. So roughly about that 50% mark still. So this one's the one that's more often used these days and is a lot more popular. So there is a nutritional product out there. It's the only one on the market, supplementation. So I just brought something to show you. So it's a product made by a company called Nutricia. It's called Keto Cow. So it comes in a powder or it comes in a little drink as well with added fibre. So it might help with constipation. It's a formula. It's got nutrients and vitamins and minerals in there, so it helps obviously with any sort of nutritional deficiencies. Some people may like to be on it full time, but you could use it in combination with a diet just to help you meet your nutritional requirements. Obviously, the flavour of these sort of foods. If anyone's had nutritional supplements in the past, whether in the hospital or for any other reason, it's not like drinking a chocolate milkshake. Do you know what I mean? It does have a particular flavour, but the good thing about them is that you can meet nutritional needs. They do meet your protein requirements. You are getting the ratio, and it can help control that. So it's just something out there we may use for supplementation to a diet to help achieve the outcome, really. And I just thought I would show you an example of a diet this is used up in Queensland Hospital, where people are hospitalised for it, so it is a 4-to-1. Just to give you an example of what sort of things would be on a menu. So In the morning, they'd have a cheese omelette, so there'd be no milk in that omelette, so it's just cheese and eggs, really, scrambled up. And then morning tea would be cream and strawberries. Strawberries are really low in carbohydrate, so as you can see, it's only 20 grams, so we're talking 2 strawberries, and 30 grams of cream. At lunchtime, it's a salami snack, so it's not just salami in a little snack pack, with a little bit of rock melon. 3:30, they have some mayonnaise, some carrot sticks, and some diet cordial. And at dinner, they have a specialised ketogenic meal which they make up. So there's beef stroganoff, or they do a chicken korma, and the ratio of those, you see, is very high in fat, 35 grams of fat and 3 grams of carbs. The recipe of this actual meal, I was going through, it's very different to, I suppose, the beef stroganoff we would have generally. So it's more or less beef and oil and a few light vegetables. The chicken korma is like coconut milk, oil and chicken with a few beans in it. So it's not that lovely, and spices and that all don't matter. There's heaps of spices and garlic and all that, but it's not the, I suppose, the creamy one that you're probably used to. So it is slightly different, but that's how you could kind of achieve a ketogenic diet. As you can see, it's not, it's probably very different to what you guys eat now, generally, because it is quite restrictive. Does anyone have any questions at all? I think yep, you've got them there.
That diet,
Yep.
is that going to give you enough energy to work?
Yeah, so that's just an example of a diet. So this is for an average person. So every person would have different needs. So exactly, if you're working or you're doing a lot of exercise or you have higher energy needs, well then obviously you would need a lot more than that. So this actual particular diet, I would put this at the children's hospital. So this is possibly for a child under 10. So it wouldn't be a diet that I would put someone like yourself on, a male, who is working, especially working, to have a lot of physical work. No, you would have a lot more than that. Yeah. No, that's a great question. So that's why it's very individual. So at the end of the day, what you would do is work out what your total energy requirements are, and then you would work out the ratio of 3 to 1 of carbs to fat, and then I'd work out a diet plan, more or less, for you to follow and to eat with exact grams and so to make it specific. Because at the end of the day, you need to be in ketosis for it to work. And it takes about 4 or 5 days to be in ketosis. So if you put all to switch over. And then look, I sometimes use these diets not just for people with epilepsy, but sometimes I use a low carbohydrate diet even for some people for weight loss. So, the first week's generally the hardest, and then it does get a little bit better. This is quite a lot lower though than the typical low carbohydrate diet you may see in the media. That typical low carbohydrate diet we see in the media has about 20% carbohydrates. So we're looking at about 5 for people with epilepsy. Yeah.
Any benefit from using low GI?
No. So the low GI, well, there's no research on that. The low GI still contains the same quantity of the carbohydrates. So the low GI, I suppose, it will affect the insulin and that side of things, but that hasn't seemed to have a relationship with the brain. So for fulfillment, if you only had to have 1 serve a day, I would definitely reckon a whole grain sandwich rather than a white, because at least it would keep you a bit fuller. There was no, whether it's low GI or high GI, it doesn't really matter. Yes. That's okay. Yes.
I was just interested about I've got one for epileptic and I've got someone that's diabetic.
Yes.
I was wondering, is it in the same kind of ballpark when they get ketoacidosis and take from the fat cells?
Yes, I see where you're coming from. Yes. It works, with diabetics, I suppose we're working on, ketosis, but we don't generally recommend low carbohydrate diets for people with diabetes. While they go a bit... Yeah, it's not as extreme. This is a lot more extreme than your diabetic one. Yeah, definitely. Diabetic one, they can, I suppose, get low blood sugars by just missing, half a day. Do you know what I mean? Whereas this, that it would be the full day. Yeah. Yes. very interesting question, which is definitely one of the side effects. So even gallstones and kidney stones, you are running at a high cholesterol. The only thing is that I suppose we would recommend good fats like canola oil, sunflower oil, rather than vegetable oils. But yes, there is that is definitely that is one of the main problems, and there's not a lot of long-term studies done on people who have been following the diet for long-term. That's with all generally high-fat diets, so it is a massive risk factor. I suppose that comes to then outweighing those complications versus the effects it's having on your body and your seizures. So, the cholesterol is maybe possibly a lower priority when we go down the priority, or maybe it's not. Maybe, if you're having a seizure, once a month or something like that, you think, probably not worth it. But if you're having 10 a day, maybe it is. So, that's something that is very individual to each person. Yeah. But yeah, definitely high cholesterol would be one of the things that would be getting checked. Highest cholesterol I've ever dealt with, 9s, 8 9s. I see a lot of 7s. Generally those type of people who are on 8 or 7.5 plus do have medication as well. Some doctors allow patients who are between that 6 and 7 to trial diet alone for 3 months, and if the diet can bring it down, then great, they don't need the medication. But on the really high people, yes, they do medication, and they will always do diet as well for the rest of their lives. Yeah. Yep. 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 Mhm. Mhm. Mm. Okay. Because you would be having a high fat diet, that you were the one that put your hand up as well, saying you had tried that diet. So, yeah. And look, it's that's a discussion to have with the doctors, definitely, because if your cholesterol's high and then you're having 10 seizures a day, you think, if we can have some medication for the cholesterol, then yeah. Put a self on. Yep. Yeah. So very interesting. Okay, thank you everyone. And I'll look at this, my cards and things at the back. If you want to chat, you can email me or whatever, give me a call. If you need any help, just let me know. Okay? Thank you.
Thank you very much, Claire. That was very informative. Next up, we have a patient's perspective, so I'd like to welcome Helen.
Good afternoon. Dr. Gordon, I'm not sure who it is. Anyway, thank you for inviting me to share my story today. Before I start, I'll just quickly outline. I do have tonic-clonic seizures and have had for, well, I would say longer than most of the people in this room, I think, and also myoclonic seizures. However, my journey began at the age of 11, when a group of friends and I decided not to play the mandatory sport after school, but wag it. I guess in a way that was better than being on the hockey field, as I had my first seizure and was incontinent. Within a few days, I was taken to Sydney to see a neurologist, had the EEG and prescribed Dilantin and Promenol. Over the years, other medications were added to the Dilantin. I have always looked back on my school days as very happy ones. However, in retrospect, I have probably, I have looked back on my school days as very happy ones. However, in retrospect, I was probably a little troubled teenager as the myoclonic jerks became more prevalent. About 10 years after leaving school, I met one of my teachers through a mutual friend. She had no idea I had epilepsy. The principal of my school had not told the teachers. This was quite upsetting for her when she realised that the stumbling and knocking of pens and pencils off the desk was not bad behaviour, as written on school reports, but part of my condition. There were little choices as far as careers. I always wanted to nurse. This is not the best choice. However, my neurologist at the time did not discourage it. My parents insisted that I undertake a 12-month business course first, as being a backstop. Jerking arms on a manual typewriter at times was not fun, and looking back, shorthand did not always go well. However, I managed with good results. Not growing up in a technological age, when I did go to TAFE to do a computer course, at least I could type. My heart was still set on nursing. My neurologist had said my EEG was within normal limits and gave me the clearance. I was very happy, although the little jerks were not far away. I was very happy, although the little jerks, I was very happy. We had a lecture one day about epilepsy. It was something said that day that I realised that the jerks, the word myoclonic had never been used, were part of my condition. I continued on, however. However, one day I had a tonic-clonic seizure in the wrong place, followed by another. A couple of seizures in the wrong place ended what was probably the wrong career for me. I was dismissed on medical grounds, and although very disappointing, that was the correct decision, as this was done back in the 60s. I returned to Orange, realising that it would take time for things to settle. I was offered a position as a legal secretary. I accepted this and enjoyed it, however, only to a point. I also spent some months working in the Department of Social Work at Sydney Hospital. This came up and offered by a friend, and jobs do not come that way now. I loved that, however, travelling into the city from Pymble, the long days proved too much. My seizures worsened, so I returned to Orange, again disappointed, but with the words from a very wise aunt, as one door closes, another will open. The door did open when, after much encouragement, I undertook a graphic art course by correspondence. This was the best decision, with encouragement, I could make. I was able to do this at home. I enjoyed it, and in the ensuing years, I did a lot of calligraphy, design fruit boxes, and also a considerable amount of screen printing. At this stage, I was playing golf and enjoying a relatively full life. Dilantin did cause a rather severe reaction. However, in time, got back to normal. My marriage ended. However, I managed to get back to my art, golf, and involvement in my community. My father died in 1980. I, as you have probably gathered, was living at home with my parents. Naturally, this was a very difficult time for my mother. I knew she often wondered, not of her future, but of mine. She was brave and strong. We continued to live together. She died in 1999 after nearly 18 months in Wanthama nursing home, 2 months short of her 90th birthday. I continued to live independently. I think it was around 1981 that Dr. Gordon came to Orange. I have been under his care ever since. I was not an easy patient, but received much encouragement from him. My epilepsy was not at this time controlled. However, towards the end of 1989, I was referred to a neurologist in Sydney with the view to going on the gabapentin trial. After meeting the initial criteria, I was accepted onto it. At the beginning, this meant fortnightly, then monthly visits to Sydney. Good communication between me, the neurologists, and my GP was imperative, so we were all fully informed. Some of the consequences of this trial were not good. However, in looking back, there were some instances that helped me understand my condition. I spent about 3 or 4 years travelling to Sydney. Sometimes I feel a lot more could have been resolved in Orange. However, that is the past. Unfortunately, I did have a number of very nasty seizures when medication was withdrawn. This, I feel, has made a difference to the person I was. And memory of parts are now a little sketchy. Dr. Gordon helped and encouraged me at that time, and this was invaluable, as was the help given me by others and family. The Epilepsy of New South Wales, the Epilepsy Association of New South Wales, in 1989 appointed a support worker to Orange. This made such a difference to so many, particularly bringing awareness and education of epilepsy to our community. A support group was established. So many families and individuals were given, for some years, support. The work done by the epilepsy nurse was invaluable. Today, it is not possible to have an epilepsy nurse or support worker. If one lived in Sydney, by appointment, a face-to-face session may be arranged. However, most is done online, webinars, and of course, you can make a phone call. The people of the Central West deserve more. Although my epilepsy is not fully controlled, I feel that the last 20 years have been very productive. The earlier few years have not been good. I am now far more involved in activities at home in Orange, particularly as a member of the Country Women's Association. I play croquet 2 to 3 times a week and am at present captain of the Orange City Croquet Club. I enjoy probably, also I go to the gym, involved with my church and many other things. I enjoy probably as full a life as many others of my age. At times a little confusion sets in, although I just have to keep going. I am free to do as I wish socially, thanks to my family, friends, and the taxi cabs of Orange. I have been able, to an extent, keep the myoclonic jerks controlled or reduced. I carry a little Rivotril in my pocket or bag, and when they start or I feel I'm not going to have a good day, I take them. This certainly helps my confidence and, of course, safety. The tonic-clonic seizures happen from time to time. However, when I get over them, life continues. Thank you for giving me the opportunity to share this afternoon with you. Beck, I wish you well as you work towards the establishment of the support group and maybe some funding for a support worker or nurse. To you all who are travelling similar journeys, best wishes. And to the medical profession, listen to your patients, communicate with them. I have been
Thank you very much, Helen, for sharing your experience with us. Now, our next speaker is Cameron, who unfortunately can't come today, but he has put a video together for us. So if you'd like to look at the screens, we'll play that.
Good morning. My name is Cameron Prevost and I am the Chief Executive here at Orange X Services Club. Thank you for the invitation to speak on this occasion. I would like to say congratulations and well done and thank you to Beck for driving the implementation of this information session, to which I'm very pleased to be able to support. I'm also very sorry I could not be here today in person as I have other work-related commitments. So Beck asked me to record my thoughts for you to listen to. So, my story and the reason for talking to you today. I was diagnosed by Dr. Gordon just over 12 months ago with epilepsy as a consequence of a benign DNET brain tumour. I'll let Dr. Gordon at his session pronounce the long version of DNET and pronounce it properly. My story, looking back now, with the benefit of hindsight, I think, or I know, I have been living and getting by with this condition for many years. I recall what I believe was my first seizure in late 2008. It took me almost 12 months to feel normal again. And at the time, I just thought I was pushing myself too hard in a new role. My second event was in early 2015 in the gym. And again, I thought the same thing. Not really putting two and two together. However, my third episode was in LAX airport in the USA, awaiting my connecting flight to Chicago. It was a very frightening and confronting feeling, waking up, confused, not knowing where I was or why I was there, and being put into an ambulance and transferred to a Los Angeles hospital. However, after coming to and actually realising where I was, I had an MRI with no real outcome and discharged and put on 250 milligrams of Keppra twice a day. As I said, discharged from the hospital to continue my trip. I do remember the trip and the places, in particular the visual aspects and experiences. However, I do have difficulty recalling the names of many of the venues. Upon returning to Australia about 10 days later, I visited the GP, who said, well, cardio and neurological, let's have a look. I do recall the fear of the unknown. I knew something was not right. I did suspect the worst, but I thought I need to take a positive approach to this and not worry about things that I can't control. So I played the waiting game. First, the cardio test, it came back all clear and was okay. So then I knew this was not good. I thought to myself, you can get a new heart, but you can't get a new brain. So I'm done. My first meeting with Dr. Gordon was a bit of a blur, with my mind going a million miles an hour and struggling to comprehend and recall the discussions at the time. One of the hardest things was the waiting between my first consultation, the testing, the second consultation for the diagnosis, and then a further consultation with a neurological surgeon to be told it was not really an option due to the location of the tumour. And then being told we need to wait another 6 months for another MRI to determine the growth rate was a pretty tough time. However, during that 6 months waiting time, I decided again to focus on the positives. And I thought, there's always somebody worse off. The matter was beyond my control, so don't worry about something that was obviously outside of my control. One thing I did do was check my life insurance to make sure it was in order, because I thought to myself, how was the family going to be if I was not here? 6 months later, the diagnosis, slow growing tumour, and now we just manage it, hopefully, with medication. And we will have 12-month scans to watch the growth and observe any changes. And I guess I'll be doing that for the rest of my life. So in saying all that, the lessons for me, in hindsight, are: take the medication the doctor prescribes. Do not change when a chemist tells you they're all the same. I had some issues during the last 12 months getting my medication level correct. However, I think some issues were compounded by the chemists not providing the actual prescribed medication. As I said, don't let them tell you they're all the same. I really did struggle with my mental health during the period, or during the waiting period, and I guess I now sometimes think about how long did I have, how long do I have left, and obviously what will happen to my family. The support network, as Beck is proposing, would have certainly helped, as I was determined not to consult with Dr. Google or overthink the matter. So the way I got through was just stop thinking about the matter and focused on positives. So I focused on work to keep my mind active. I stopped worrying about the small things. One thing I did have to turn to was alcohol at night to try and turn my mind off to enable me to sleep. Also, after getting my mind around the matter, and I found the more I talk about my issue, it has certainly helped and resulted in a much more positive frame of mind for me. I do look at my situation in a positive light, as it has enabled me to stop worrying about the small things, speak my mind, and not let things play on my mind, and enjoy what I have. As in my mind, there is always somebody worse off, so enjoy what you have. I do also wonder why 2 visits to emergency hospital here in Australia after 2 seizures, I was not diagnosed. However, 1 trip in the USA most likely revealed the truth. I am realistic, but also optimistic about my future. So in closing, I again congratulate Beck and the team behind this initiative, and my recommendation is to get a group together to enable us to all talk about our experiences. The more I talk about the matter, the more it helps. Thank you very much.
So we will move on to Dr. Gordon now, who's going to come talk. Dr. Gordon was trained in London and Sydney, and he has been in practice in the Central West since 1982. He was the first country-based neurologist in Australia, and he has a particular interest in epilepsy and the management of all varieties. So let's give a warm welcome to Dr. Gordon.
Thanks, Beck, and I think there are a few thank yous that need to be given. Firstly, to the Ex-Services Club for allowing us to have this meeting here, and secondly, to the generous sponsoring of UCB, that is much appreciated. Now, what I would like to do in this talk is to go through a lot of aspects of epilepsy and highlight some of the newer things that are going on at the moment. Now, firstly, we need to go through what is the definition of epilepsy. Then I'll give you some background history, and I think it's always important when you look at current treatment and management of conditions such as epilepsy, it's always good to just look back at what used to be. And We talk about medication and investigations, surgical management, and the newer fields which are really becoming extraordinarily important, genetics and what are called channelopathies, I'll go into that in detail, and immunology. Now, if you talk to geneticists, everything's due to genetics nowadays. If you talk to an immunologist, everything's due to immunology. Truth is somewhere in between. What is epilepsy? We define epilepsy as a tendency to recurrent seizures, which are of cerebral origin. Now, epilepsy really is a process caused by a large number of different entities, yet it gets treated as if it is a disease. But really, it's best to think of epilepsy as a symptom. It's a symptom of underlying disease processes. Because when you look at it, people can have epilepsy due to a genetic problem, they can have epilepsy due to a stroke, cerebral hemorrhage, abscess in the brain, head injury. There's a lot of different things that can lead to a tendency to take seizures. Now, when you look at seizures, they're associated with an uncontrolled discharge of electrical activity within the brain. And one of the simplistic ways I look at epilepsy is it's like you've got a short circuit. You've blown a fuse so that the brain doesn't function normally. And it's an electrical discharge. Now, the definition is clinical, and it's based on details of seizures. Now, you really have to have recurrent seizures to make the diagnosis. And one seizure doesn't usually make a diagnosis, although on occasions we will make the diagnosis if a patient has an extremely abnormal EEG with a lot of epileptic activity going on. We know that they're at risk of further seizures anyway, so that's an exception. And one very important point that I'll get patients referred for an EEG by the GP wanting to exclude a diagnosis of epilepsy. A normal EEG does not negate a diagnosis, and one does not need an EEG to make the diagnosis. But it does give supportive evidence as to particularly the type of epilepsy from which the patient suffers. Now, if we go into a little bit of history, epilepsy is actually a term derived from Greek, and those of you who are Greek scholars will know that that is epilepsy, which originally was a term meaning to seize or attack, and in its earliest usage referred to virtually any affliction by any disease, but over time it's become restricted to the people who have a tendency to take seizures. Okay? Now, epilepsy is actually one of the oldest diseases known to man, and there are quite detailed descriptions going back to Mesopotamian times in the 5th millennium BC. Mesopotamia, from the Greek, is in between the rivers. There's the old Tigris and the Euphrates. So it's in where modern-day Iraq is. And they talked about Antisabu, which was the falling disease, and also Beluru, which is the name of the demon who was lord of the roof beams. And this referred to the fact that a lot of people, when they have a seizure, will have that movement of their eyes and head, so they're looking up. And they're looking up at Beluru. So you can see that they're making a very sort of descriptive analysis without getting to the facts. Now, there's also Ayurvedic writings in India around the same period. So you get 5,000 years BC, and they call it Ashpak. And there are detailed descriptions of various different seizure types in those sort of writings. And the school of Hippocrates was credited, or is credited, with the first known attempt at a scientific explanation for epilepsy, with, interestingly, a book on the sacred disease. In that time, having a seizure was the gods entering your body. And people used to put it on because people like Julius Caesar were said to have epilepsy, but I doubt it. Certainly Emperor Claudius did. But people used to put it on because it was the sacred disease. Sorry, can we go back? And that was in Greece about 400 BC. So you can see it's a very long time ago that we're talking about. Okay? Now, physicians influenced by Hippocrates and a later physician called Galen practiced what they called the scientific medicine of their time, which they considered natural, as opposed to supernatural. And treatments that were used included diet, hygiene, and blood was considered to have curative powers. And people used to go to the Colosseum, and the people fighting at the Colosseum, when they bled, people would go and get their blood. It was considered to have curative powers. Powdered skull was also used, peony, mistletoe, garlic and onion were prescribed. Also, there were some surgical procedures where they put holes in the skull, cauterise it, basically singed tissue. And also, as the theory was at one stage that an over-exaggerated sex drive caused seizures, castration was also used. So you're looking at a background of a hopeless sort of situation. Galen, 500 years after Hippocrates, called epilepsy, listen to this, originating in the brain, he called it idiopathic. Now that term is still used to this day, idiopathic, which we now determine as of uncertain cause, of unknown cause. We call it idiopathic or protopathic, and from outside the brain is sympathetic. Now what he's talking about is seizures that are focal in nature and then become more generalised as being the sympathetic ones. Now, he described two types of sympathetic epilepsy, one resulting from the body's attempt to remove irritant substances from the stomach. And that's a very common onset to temporal lobe seizures, where people get a funny feeling which rises. And the other was irritation rising up from the extremities, where people have a focal seizure which starts, say, in an arm and then spreads. And Galen introduced the term aura, which is still used to this day, and it translates to breeze. But an aura is the onset of seizure. It's not a warning to the seizure, it's the start of the seizure. Now, in 1857, Locock was the first person to use anything in the way of medication that was effective for the treatment of epilepsy. Locock was a gynaecologist, and the theory was that if you reduce women's sexual urge, you will fix their seizures. So he gave them bromide for the wrong reason, but it worked. And then in 1912, Halpman introduced phenobarbital. And the interesting fact is that was 1912, and still throughout the world, phenobarbital is the most commonly used medication for the treatment of epilepsy, because in the third world it is cheap. And a lot of what we get in this country, the medications are extremely expensive and they can't afford it. Dilantin, or phenytoin, was introduced in 1937. And interestingly, what happened with Dilantin, or phenytoin, was that Merritt Putnam approached Park Davis and asked them whether they had any drugs that they'd used for sedative purposes, because their theory was that if a drug has a sedative effect, it will have an anticonvulsive effect. And phenytoin was made in about 1905, I think it was, and then they resurrected it, and it has been and remains an extremely good medication. Primidone, or mycilline, was brought in 52, and carbamazepine, or benzodiazepines came in 1960. The carbamazepine, or Tegretol, came in 62. So you see, it's 54 years ago, and that drug is still very widely used. And the valproate story is absolutely fascinating. This particular group used valproic acid, which is an organic solvent that had been around for 100 years, and they used the organic solvent to dissolve the series of drugs that they were testing for anticonvulsive properties. And they found that every drug they tested had anticonvulsant properties, and then the penny dropped. They found that valproic acid was the agent that was active. Now, what about new advancements? We've gone through the history. It's easy to say, but I personally believe that the biggest advancement in modern day epilepsy treatment is dedicated epilepsy units. And today we have the pleasure of having Andrew Liesel from Westmead, from the Comprehensive Epilepsy Service there. And the thing that I would say is that when I first started in neurology, epilepsy was considered as something that anybody can do. Now, it's a completely different scene. You've got the dedicated units. The research has been enormous, and that has made a huge difference to a whole lot of people in our community. Also, the more sophisticated investigational aids have been a great aid to investigation and management. The new drugs we'll talk about, and also a selection for surgery. There was a program, now this is going back in time, when Ray Martin used to have the Today Show, I think it was called, on the television. And he had this Dr. Wright who came on talking about this new treatment for epilepsy with the surgery. The first surgical procedure was done by a guy called Horsley in 1886. So it's not new, but what is new is the selection is far better. But also we're recognising the immune mediation of some of the epilepsies, and also there's a far greater emphasis these days on the genetic influence on epilepsy. Now, if we go through the investigations, and I'm going to show you some things because I think one of the things that most patients don't see is their own EEG. And I like having my digital EEG with the screen, I can turn it around and say, there it is. Now, the digital EEG has revolutionised EEG. Before digital EEG came in, you used to get a paper recording, and what you got was what you got. You couldn't play around with it at all. Now, I estimated that, and I'm sure Simon Hammond would say exactly the same, that if we were still doing paper EEGs, if we'd kept the recording, we'd have 2 or 3 rooms full of paper EEGs, whereas now we just have a computer. And the digital EEG allows far better localisation of epileptic abnormalities, and it's also, very importantly, able to interface easily with video recording to give you both the clinical and EEG characteristics of a seizure at the one time, which is most important. And EEG monitoring obviously has become the first step in the assessment for surgical treatment. But also there's the ease of storage, and with anything digital, the retrieval of data is just so much easier. And more sophisticated recordings, such as some I'll talk about, are made a lot easier with the digital technology. But again, I say that an overall rider is a normal EEG does not negate a diagnosis of epilepsy, but if you have recurrently normal EEG in a patient with supposed severe epilepsy, you get a bit worried. Yeah, this is an EEG from my lab. Now, a lot of people would accuse neurologists of being squiggle-gram readers, but basically what you're looking at is you have electrodes placed over the scalp and you interlink the electrodes in certain fashions. So I know John Dunn would be horrified that it's coloured, but when you look here, that's the right side of the brain from front to back around the temporal lobes. This is the left side front to back, that's midline structures, and then you've got front to back there, front to back there, right and left. Now, you see that there's a very nice rhythmical recording. This is actually what you'd term a textbook normal EEG, and there are certain numbers of waves per second. Each green line is a second. So you count 1, 2, 3, 4, 5, 6, 7, 8, 9, about 10 of those waves per second, which is normal. That's what we call the alpha rhythm. Now, contrast this, not hard to see that there's a consistent difference between the two sides of the brain. And what you've got here is what we call a spike. And you can see that the spike goes up here and down there. And when we have that change like that, we call that phase reversal, which tells us where the discharge is coming from. The other thing to see is that as well as the spike and slow wave, you've also got it here in the other leads here. But you can see that there's a degree of slowing, so that you'd say this person has a focal epilepsy, and with the slowing you'd be keen to make sure as to whether there's an underlying lesion such as a tumour. This is a different one. This is a child, and the neurologist would be aware that the child's asleep. And this is a child who had a seizure about an hour after going to sleep, and the parents were alerted to the fact that the child had a seizure by the child gurgling, and they come in, the child's having a seizure affecting face and arm. And you've got this, again, this sharp wave or epileptic discharge, which you can see undergoes that phase reversal at the electrode common to those two channels, which is right mid-temporal. And there's some little discharges here as well. So this was what we term benign epilepsy of childhood. Whereas this is generalised epileptic activity. Now you see that no matter what lead you look at, it's all over. And this is a patient who was actually in status or continuous fitting. She'd get out of a seizure, go straight back in. But they were minor seizures, they weren't tonic-clonic seizures or major convulsions. But she was in non-convulsive status. You can see, sorry, let's go back. You can see front to back that there is epileptic activity both sides synchronously, and that's generalised epilepsy. Now you know that that person, in view of that generalised epileptic activity, has a genetic generalised epilepsy. Now this is a response to phatic stimulation, and you can see the patient gets spike and wave activity. You can see the spike, slow wave, slow wave with phatic stimulation. Now one of the myths of epilepsy is that people with epilepsy should not go to discos or should not be exposed to flickering light. But in actual fact, only a small percentage of people are phatic sensitive and will have seizures provoked by phatic or flickering light. Now, if you do an assessment for surgery, you can go even further and place a grid of electrodes actually on the surface of the brain. Now, you're not going to do this unless the patient has severe epilepsy which is resistant to treatment. You can see you can hook up the electrodes whichever way you like, so you can get a recording from the surface of the brain. And the idea of doing this is to localise as accurately as possible where the focus of epileptic activity is coming from. Now that can be very important because you might have a seizure focus that's close to the speech area, and you want to delineate that so that you don't just go in and remove part of the brain and then they can't speak. Now, other investigations, magnetic resonance imaging. This has totally revolutionised management of epilepsy. The newer scanning sequences and high-strength magnets have led to greater accuracy in diagnosing areas of abnormality causing seizures, and also new scanning techniques have led to a different way of approaching what happens with seizures. And we now talk about networks of nerve cells being interconnected rather than just being a single area involved. You can see these networks on very accurate MRI scanning. In the context of consideration for surgery, it is necessary to demonstrate that a lesion on MRI is the cause of seizures, because they may have a lesion that is not the cause of the seizures, maybe coming from elsewhere. So that you have cross-correlation with EEG and other scans is necessary with the MRI. Just to show you some examples, this is a patient with temporal lobe epilepsy, and you can see that this area here, which is called the hippocampus, the Greek scholars will know that hippos is the Greek horse, and hippocampus is the seahorse. And it looks like a seahorse in a certain configuration. Now, you can see on this side that the hippocampal body is far higher in volume, or larger, than on the left side. And you'll also see the temporal lobe is of larger volume on the right side compared to the left. The left side of the scan is the right side of the body. And you can see on this different scan that it's actually a little bit brighter than the other side, and we call this hippocampal sclerosis, and that's a very common cause of temporal lobe seizures. That's a benign tumour called a meningioma, and this patient presented with seizures. And this is a patient who woke up in the morning and he was aware that the bed clothing was all over the place. And then shortly after waking, he went into this fugue-like state for a couple of hours. He was just off the air. And he came into hospital. It was obvious that he had a seizure. And in this scan, you can see that there's an abnormality of blood vessels, what we call a cavernoma, or basically it's a birthmark in the brain. But on the particular scan here, the white area signifies that he's actually had a little hemorrhage in that cavernous hemangioma. And he presented with seizures, and that showed up on the MRI. Now, you may not see that on CT at all. And that's the beauty of MRI, that it is so, you can pick up such subtle abnormalities. I always look at my own MRIs because I need to look at them. This MRI was reported as normal, but you can see that there's an abnormal area here and here. And this patient had a condition we call cortical dysplasia. Now, the importance of that is that she was having anything up to 8 to 10 seizures a morning, virtually every day. Dog's life, medication not effective, had surgery. I don't know whether you operated on her, Andrew, but had surgery, seizure-free, on seizure-free now for about 4 or 5 years. Driving, not a problem. So, cortical dysplasia, and those sort of things can be very subtle. The group from Melbourne, the Austin Hospital, presented at their Epilepsy Society meeting where they showed actually I think it was ANZAN, the Neurology meeting, where they showed these little lesions at the very base of the little indentations in the brain causing the seizure. When that was removed, the patient was seizure-free. Now, there are other scans, PET scans. It's not a scan you give your dog or cat. It stands for positron emission tomography scanning, and there's also SPECT, which is single positron emission computed tomography. Now, the scanning techniques use radioactive isotopes, which either measure blood supply to the brain or measure the actual metabolic activity of brain tissue. The PET scan measures the brain activity. The SPECT scan looks at blood supply. Now, during a seizure, the blood supply to the area of the seizure is increased, and the scan can show where the seizure is, or if you do it just after the seizure is finished, where it has occurred. PET scan can show areas which doctors used to talk about scars, where there's decreased metabolism. And both scans really are integral to the assessment of seizure. This is a SPECT scan, an ictal SPECT scan. You inject the radioactive isotope at the time or immediately after the seizure. And you can see here, normal MRI, but you've got this area of increased vascularity and therefore increased uptake. That's where the seizure has been occurring. This is another one in a different area. Sorry. You can see there that it lights up like a beacon, whereas you can't see very much on the MRI. Now, they can do fuse the SPECT scans with the MRI scans to get more accurate analysis. And the PET scan, actually, you can see here that's a normal area of metabolism in the temporal lobe, and you can see that there's a gross underactivity in that temporal lobe, and that would be, if concordant, would be suggested that that area is where the seizure comes from. Now, newer medications. I think before talking about any of the newer medications, one has to say that they're not the answer to a maiden's prayer. They help and they have a place, and I'll go into it in detail. The first newer medication was one called vigabatrin. For some reason, some call it vigabatrin, I call it vigabatrin, and brand name Sabril. And this was brought about by research which showed that during seizures, particularly children with febrile seizures, the level of the transmitter substance called GABA in the brain or in the spinal fluid reduced dramatically. And the idea of vigabatrin is to block the breakdown of GABA so that you get increased GABA, which should be anti-epileptic. Very effective medication, but the Australians led the field a bit in this. It was associated with up to something like 41% of patients developing visual field problems. So that restricted its use. It is still used as the drug of choice for babies with infantile spasms. The next one off the block was lamotrigine, and that is still one of the, I would say, first-line treatments, but the restrictions on the PBS say that you're supposed to have tried others before you tried. Then Neurontin came on with gabapentin, which is actually more commonly used for treatment of pain now than it is for epilepsy. Topiramate came on the scene, and topiramate has multiple means of action. And interestingly, from the talk on the ketogenic diet, one of the effects that topiramate has is to block an enzyme which causes the acid level in the blood to increase. So whether that's how it partly works, it has other means of action. Gabatril, tiagabine, that also can have the similar effect as the vigabatrin. So it is not used. Oxcarbazepine, as you can see, it's like carbamazepine. One which is basically a variant of phenytoin, called phosphenytoin. And the point of this in usage is that it can be given intramuscularly, whereas phenytoin or Dilantin is irregularly absorbed intramuscularly and has to be given intravenously. I've heard the quote that Dr. Bleasel has been heard to say that the streets are lined with Keppra. It has to be the most overused medication in hospitals there is at the moment. And there's one reason, that it doesn't interact with everything. And it's a very effective medication, but it also has a lot of nasty side effects. So I would tend to use others first, but not hesitate to use it. More recent ones, Vimpat, I've had some absolutely marvellous benefits with patients. And one guy, his life was a misery. He would have a seizure and a prolonged postictal state, and he could not live alone. On Vimpat, he's out living alone. Marvellous. Sinizamide was available in Japan for about 20 years before it became available in Australia. And perampanel. I don't know what other neurologists experience with perampanel, but I call it a bipolar drug. It's either extremely good or it's extremely bad. And I've had some awful side effects, but I've got one guy from Dubbo who's never had a day free of seizures in his life until perampanel. And I saw him in mid-April, and in April he'd had 2 seizures that month, both on the one day. That's amazing. So these can add in, and often you can get dramatic responses, particularly with Keppra, lacosamide and Fycompa, but the others have their place. Now, it's hard to establish the place of the newer AEDs, and on occasions when I've given talks to general practitioners on the new drugs, I say that the experience that I've had with the new drugs tells me how good the old drugs are. One has to remember that once one has tried 2 or more anti-epileptic drugs to treat a patient's epilepsy, the chances of another agent inducing seizure freedom are remote. And one of the very sad things you see about studies, they talk about a greater than 50% reduction in seizure frequency. To most patients, that's meaningless, because any seizure is one too many, and so patients want seizure freedom if possible. And once I was asked at a GP conference what was my definition of good or successful treatment of epilepsy, and my answer was simple: no seizures and no side effects. But you may have to accept side effects to get seizure freedom, or you may have to accept some seizures to not have side effects. And you don't replace a problem that occurs part of the time with a problem that's there all the time just to gain seizure freedom. Despite the chances being remote, my attitude is that I would never deny the patient the possibility of becoming seizure free, because we all know the difference is dramatic. And there are restrictions placed by the PBS guidelines, and most of the newer medications are available once you've tried other medications and they haven't worked or have not been fully successful. But what you find is that a considerable number of us tell little white lies. And one major benefit of the newer medications has been the side effect profile is relatively less, and also, importantly, often there's a lack of interaction with other drugs, which can be extremely important. For example, I had a fellow who was on warfarin. Now, on carbamazepine, he was taking 16 milligrams of warfarin a day. Switched to one of the agents that doesn't have any interaction, his warfarin dose is 6 milligrams a day. So it can be a major reason for changing. And also, you've got the newer medications, I'd say, have added to the armamentarium, but they're not the answer to the problem. And in my experience, they add a small percentage increase in the numbers of seizure-free patients, but that small percent is well worth it. Now, anti-epileptic drugs, in general, patients will respond to the suggested first-line treatments, and when you look at it, estimates are about 70 to 80% of people will be seizure-free on treatment. There may be reasons to use different medications and things that may influence your need for change: incomplete control, untoward side effects, potential for teratogenicity, and the big one to worry about these days in women of childbearing age is valproate, sodium valproate or epilepsy. Because the studies, and these were done by the Australian Pregnancy Register, suggest that dosages over about 800 or 6 to 800 milligrams a day are associated with at least a 15% risk of congenital malformations. Totally unacceptable. So it's something that it's changed our management, that you've got to think twice about women of childbearing age being on Epilim, particularly at high dose. And you've got to also look at long-term effects, and one of the problems with a lot of the older medications is the effects on bone health. And also you have to think about the PBS availability and cost, although most of us will not think of cost when we're looking at our patients' welfare. Epilepsy surgery, really this is only considered when there is failure of medical therapy, and you'll get neurologists who will say having tried 2 drugs is failure, others will say 3 or 4 drugs. And people with, say, a generalised epilepsy, because the seizures occur throughout the brain at one time, they're not suitable for surgery. So that it really is only the epilepsy group that have focal seizures coming from part of the brain. And one must remember, and this is a point that patients need to be told, that they don't always get off medication. But they may in fact be seizure-free on medication, but they may not be able to get off it. But surgery's been done since 1886, when Victor Horsley operated on 3 patients, one of whom was his, I think, son or daughter. And that's not a new procedure. But what is new is the detailed assessment that patients go through. And it's not easy. It's a very difficult assessment. Procedure is performed, removal of parts of the brain, and in extreme circumstances one may do a total removal of one side of the brain. I've had one young man who's had that and he's not had a seizure since he's had it. His life's been totally changed, and the fact that he's got a weakness down one side wasn't made any worse. It's just the same. One can cut the connection between the 2 sides of the brain in order to try to stop seizures becoming generalised so that they don't lose consciousness. And other procedures done, stimulators of the vagus nerve. There's also some reflex cortical stimulation where people will stimulate an area in response to recorders on the brain surface picking up epileptic activity occurring. That's very early days. Now, genetics. There are definable epileptic syndromes with a proven genetic basis, such as the first one described, which was nocturnal frontal lobe epilepsy. This was the first in the world described by Professor Sam Berkovic and his group in Melbourne, and they isolated a gene in this particular family with this particular type of epilepsy. There are other genetically inherited epilepsies, such as the idiopathic generalised epilepsies, which are now classified as genetic generalised epilepsies. But you have to say the situation is very complex otherwise, and it is considered that genetics have an underlying role in most epilepsies. And the way I simplistically look at it is, if you have something like a cerebral hemorrhage, now a percentage of people will develop epilepsy afterwards. Now, why do some do and some don't? My attitude is that it's their genetics that predispose them. That's not true. Now, our nerve cells on the lining of the nerve cells, what we call the nerve membrane, have little holes where little ions or little elements like sodium, potassium, chloride and calcium can move in and out of the cell. And that movement in and out of the cell causes changes in the electrical activity in the nerve cell. And there are various of these. The most common are sodium, potassium, calcium and chloride channels. And a lot of what we do in terms of the medical therapy is based on effect on these channels. The movement of these chemicals called ions across the cell membrane causes changes in the electricity of nerve cells, and the ions move through these channels, which can be opened or closed. And a lot of the effects, as I've said, is via these channels for the AEDs. The ion channels have differing effects on electrical activity, with some being excitatory and others being inhibitory. But there are epileptic syndromes which relate to genetic defects in some ion channels, and the best example is one called Dravet syndrome, which is a defect in sodium channels. And just as a little aside, I saw a patient from Dubbo years ago who, for all his life, parents were guilty because they had him immunised, and he developed this brain rot due to the immunisation. But Sam Berkovic and his group in Melbourne looked at a lot of these people and found in fact that they had Dravet syndrome, and that's what this boy has. And I walk on water for those parents because I've relieved that enormous sense of guilt they have, because it's a genetic disease which was provoked by the temperature associated with immunisation, not caused by the immunisation. That's most important, and a lot of the anti-immunisation propaganda quotes those sort of cases, and it's not true. Now, hopefully this will work. Yeah. Sorry about that. This is a video. That's on there. a lady with a specific type of seizure, which has been written up by Andrew Bleasel and also Ernie Somerville and others in Sydney. It's called a faciobrachial dystonic seizure, where people get a specific movement of the arm and the face, and it's absolutely characteristic of one of the immune system disorders causing epilepsy. Go on. Sorry? Just
Close your eyes.
the face contract, the arm contract, goes into a funny posture. There's a slightly better example coming up.
Right. It's all good.
This condition is associated with an autoimmune, or autoimmune means an immune system response to one's own body. And we really, it's only in the last 20, 30 years or so that we've become aware that a small percentage of new onset epilepsy is caused by a malfunction of the immune system, with antibodies being produced which are directed at certain parts of the nervous tissue. And basically they cause what we term an immune-mediated encephalitis. And that lady had what we call limbic encephalitis, with that absolutely classical seizure pattern, and you can diagnose it without any information. The antibodies have only recently been available for testing in Australia, and it's amazing how frequently we're finding that patients actually, that we thought had what we had termed an unknown cause epilepsy, actually have these antibodies. Now, most importantly with recognising these situations is that some are associated with an underlying malignancy, and also the fact that the seizures may not be controllable without treatment of the underlying immune disorder. So that often the seizures will be very difficult to control until you treat the immune system at the moment. And I'll finish there, but I've hopefully given you a bit of a Cook's tour of epilepsy, and I'm certainly open to answering any questions. Thank you.
Has anybody got any questions for Dr. Gordon?
Firstly, we talked about carbohydrates. What's the link between sugar and epilepsy and carbohydrates? What are the doctors?
Carbohydrates, I think what you can say is that the idea of that diet in terms of restricting carbohydrates is to produce more ketones. It's not that the carbohydrates as such are bad for epilepsy, because if that was the case, we would all, every person with epilepsy would have to go on a carbohydrate restricted diet. But there are two riders. One is that a low blood sugar can cause seizures, and also if you have epilepsy, a high blood sugar level can make it worse. So that's diabetic, the diabetic. We had one fellow over here in Orange who was continuing to have seizures, and his blood sugar level was really poor at 18. He changed the doctor treating his diabetes, and his blood sugar levels now are 6 to 7, and he's not had a fit for years on the same treatment. Well, you can have epilepsy caused by what you'd term a generalised disorder, where you get the electrical activity spreading throughout the brain at the one time, but you can also have epilepsy where you can have multiple areas that actually cause seizures. I had one guy years ago, this is a tragic case, he was assessed at Westmead and he was found to have a repeated focus of his seizures, and they were planning surgery, they were about to disconnect him from the equipment, and he had a seizure coming from the other side. So they deemed him unsuitable for surgical removal of tissue, and they offered him the division of the brain, what's called a corpus callosotomy. He went home to think about it, had a seizure, asphyxiated due to falling out of bed, and he died before he could actually have treatment. So he may have been okay. So you can have that. You don't always have a single focus, but if you have multiple foci, it's not easy to treat. I've avoided that. Now, I think you have to look at a position statement put out by the American Academy of Neurology. This is going back a year or two ago, and they said in their position statement there is no scientific evidence that marijuana or marijuana products is effective across the board in adult epilepsy. Certainly it appears that there is some effect in childhood epilepsy, but you may be dealing with a different kettle of fish. But I think the crux of the matter is that it needs to be basically looked at. I don't know whether you're going to run any trials, Andrew. Because it's important. And you look at other conditions like MS. Now I've got 5 of my patients who take marijuana for their MS symptoms, and it helps. And I've got to get my AT to publish this paper that I've got a fellow who's got MS and he's undergoing gender realignment therapy to become a woman. And since he's been on the treatment for that, his MS symptoms have improved ever so much. So nowadays I'm telling them you've got to change sex. But it certainly has it has a place in medicine, but it has to be established. Chris? I think what you can say is that the general rule with patients with epilepsy, unless they develop a different type of epilepsy, is that they obey a certain sort of type of presentation. Now, what may happen is that you may get some of the epileptic syndromes, which are nasty, which over time may induce a much more severe type of epilepsy. That's certainly the case. But if you deal with the more common types of epilepsy, usually the seizures will remain much the same, although they may vary in intensity. And if there is a change in seizure type, then you've got to investigate. Like I had a lady she came up from Sydney, and the first time I saw her, she used to see one of my bosses in Sydney, who's passed on, a bloke called Big Nandra, and he had diagnosed her as having an idiopathic generalised epilepsy. And anyway, I accepted the diagnosis. She had generalised epileptic activity on her EEG. There was no reason to disregard it. But she came to see me after a while, and she was having seizures which were occurring without loss of consciousness, and they were completely different. And she had a frontal tumour. And then post-surgical treatment, she had different seizures which were psychogenic. So she had 3 types of seizures, all in one. Showed up.
My daughter had EEGs prior to diagnosis that didn't show anything.
Yep.
Why is it that some people, nothing shows up? Is it just that it's something we can't receive, or is there sometimes there is no vision?
I think the easiest way of looking at it is that an EEG is a test at a point in time. Now, if the activity does not occur frequently, you may not pick it up. But the reason for doing sleep deprivation is that you tend to provoke abnormalities on the EEG, so that if you have a person who has an EEG for the first time, then the statistics suggest that even up to 40% may be normal. But if you repeat it and do it with sleep deprivation, you've still got a subgroup that are normal. And one of my most severe cases, she's got a condition called Lennox-Gastaut syndrome. My technician one time said to me, "Are you sure she's got epilepsy? You know, we've done all these EEGs and they're always normal." Yet she has drop attacks, she has fade out turns, and she has these tonic seizures, never controlled.
There are MRIs and the like, is that something?
Well, you're looking at, you can do an MRI on a patient who's just died, and the MRI might be normal. You do an EEG and there's nothing. EEG, apart from, there are functional MRI characteristics that you can look at, but the straightforward MRI, you're looking at structure, whereas EEG, you're looking at the surface of the brain electrical activity. So it's a functional look at the brain. But as I say, a normal EEG does not negate a diagnosis of epilepsy, because you diagnose it clinically. And when you see patients with possible epilepsy, the 2 things you have to try and do every time is, one, if the patient can, they can give you a description of what happens to them, and just as importantly, the eyewitness account of what happens. Because one case of autoimmune encephalitis that I diagnosed was discharged from the hospital elsewhere with the diagnosis that there was no physical cause for her problem. She was having fits. In fact, had a tonic-clonic seizure in my waiting room, went blue around the mouth, a grossly abnormal EEG, yet they still said there was nothing wrong with her. And she had antibodies to tissue, and with immune treatment she improved. But you've got to look at it. The EEG in that circumstance is faulty.
Now we're just going to break quickly for about 10 or 15 minutes for some afternoon tea. There's food, tea, coffee, water and juice up the back, so help yourself. There's also a table over here with a lot of information that's been sent from Epilepsy Action. Okay, so we'll rejoin in about 10 or 15.
wrote a book.
Are you very diplomatic about it?
How are you?
Yeah, so there was some positive outcomes from that time. Kind of in autopilot, something made a decision in your mind to do something which is just totally illogical. How would you do it? And put all that in, that's right.
Submit your lab.
me, everyone. If you can just get a plate with food and sit back down shortly, another couple of minutes and we'll get going because we are a little bit behind. Okay.
Wait, you're very busy. You keep me like that, that's fantastic. Here we go, super.
Okay, everybody, get going with the rest of this afternoon. Now, our next presenter is from Sydney, from Westmead Hospital, Dr. Andrew Bleasel. He's a neurologist who became interested in epilepsy while training in neurology and went on to a clinical fellowship in epilepsy at the Cleveland Clinic Foundation. He came to Westmead Hospital in 1996, where he's the director of the epilepsy unit. In 2010, he became the head of Department of Neurology. He has co-directed the Australian and New Zealand Association of Neurologists annual EEG teaching course, and he teaches throughout Southeast Asia and Australia. Please give a warm welcome to Dr. Bleasel.
Thanks very much for inviting me up. I'm very impressed by the first lecture. It's very interesting and entertaining. I'll cover some similar things, but I'm hoping to try and keep coming back to the patient's perspective. So if we have the first slide, or do I move them on? Okay. So from the doctor's point of view, epilepsy is an intermittent disorder, a paroxysmal disorder, and as many people who have epilepsy or family members know, you're perfectly normal in between the seizures. And for that reason, there's often no physical signs, there's no clues, outward clues to the disorder, and it depends very much on the history. And so in teaching this subject, I always say history is everything. So the correct diagnosis of a seizure, the classification of seizures, as we'll see, the syndrome, the other aspects to the history, the family history. But one of the things that's most, I think, distressing at times is that there is no test that measures the activity of the disorder. And this means that we have to titrate medication against the seizure frequency. When a seizure may have, as Jamie mentioned, terrible consequences, and yet there's no other test that we have. History is in fact the measure of whether the drugs are working. Thanks. So for people with epilepsy, there's a different set of concerns, and often the doctors don't really appreciate this. They might come in on certain aspects of it, but there are many concerns. Having the illness itself, there's still a degree of stigma about epilepsy, and To say otherwise is very naive. I think that families and patients experience this. There are safety issues. There are restrictions in the workplace. There are big issues of driving, which we'll cover. The medications, having to take a medication every day. I had clots once and had to take warfarin. I could never remember it, and I would take a handful of it twice a week, which seemed to work for warfarin, but I doubt that it works for anticonvulsants. And there are big issues for families. One of the questions people have on making the diagnosis of epilepsy and talking about it, they're thinking for their child or for themselves, are they going to have a normal life? Thanks. So epilepsy as defined by greater than one seizure, and we won't dwell too much on this, but quite a lot of people will have a single epileptic seizure but never establish a diagnosis of epilepsy. If you define it like that, there are two peak times that it occurs, below the age of 15 and after the age of 60. And they have different sets of causes, as you might imagine. More genetic causes in the early stages, sometimes things related to the pregnancy or birth, and later on, tumours and much more commonly strokes are the cause of epilepsy. Thanks. Now, a seizure, as Jamie said, is a manifestation of abnormal and excessive excitation of cortical neurons. Usually just the surface of the brain is the trigger for the seizures. Whereas epilepsy is a tendency to recurrent seizures, so not just a single seizure, even though that seizure is an epileptic seizure. Just having one of those does not make the diagnosis. Thank you. Now here are some figures which are quite important figures, and it gives you an idea about how often people might have a seizure but not have the diagnosis of epilepsy. So we start at the top with seizures. So just one seizure in life is as high as 9% of people right throughout their lives. And many of those are explained by febrile seizures in babies, in less than 5 years old. People that just have a single seizure, or people having their first ever seizure of epilepsy. If you look at the chances of having epilepsy at some point in your life, 2 to 3% of the population will have a diagnosis of epilepsy again right throughout life. If you look at epilepsy at a point in time, a point prevalence, if you like, the epidemiologists call it, it's only 1% or so of the population. But it's a very common disorder. Thank you. We need to distinguish always between a single seizure and epilepsy, and I won't. That's a very big area for doctors. Is that first seizure that you see someone for really the first seizure, and the doctor will often ask about other possible seizures that weren't recognised as such. Typically people will present with a tonic-clonic seizure, a grand mal seizure, that may have had other non-convulsive events. So that's a big issue for the doctor. Or is it, in fact, the beginning of epilepsy? Thanks. So how could we classify epilepsy? How can we divide it up and describe it? And we could look at the causes of epilepsy. We can look at the seizure types, and this is what we do very much. We look at the different types of seizures, and again, this comes back to the history that we'll obtain from the patient, from witnesses, from the family. And then we can talk about the epilepsy syndrome. Next one, thanks. Now, this is disappointing if you start with the cause of epilepsy. You'd think that would be the obvious way to characterise epilepsy, to say that we want to know what's causing it. Is it a post-traumatic epilepsy? Is it a stroke-related epilepsy? Is it a genetic epilepsy? The trouble is there aren't tests for all of those things. And this is from a very important data set that any doctors in the audience are probably aware of, that centres around the Mayo Clinic, where they have this extraordinary linked medical record system. And if they mine through their medical record with all the patients with epilepsy, they can only define a specific cause from the history or the tests that have been done in a third of people. And in 2/3, there's a group where different terms are used, idiopathic, cryptogenic, But in that group, we think that there are genetic causes of epilepsy, although the genes have been very few of them have been discovered. And again, as Jamie alluded to, there's some unknowns there, and just in the last 10 years, it seems that a number of those cases are actually an inflammation in the brain. So next slide, that's in that pool there, genetic and inflammatory, and there are obviously others that we don't know about. Some advances in scans are showing very tiny lesions in the brain that were completely missed before, and the epilepsy was thought possibly to be genetic, but in fact it's got a specific cause that you can see. But that's chipping away at an enormous pile of unknowns. So, on the basis of the cause of epilepsy, it's not very helpful. Next, thanks. What about that genetic aspect? Now, we've heard a bit about this already, and I'll put some numbers to it. This is actually quite a common concern. You've heard the term genetic generalised epilepsy. Now, that accounts for probably about a third or of the epilepsies occurring in teenage years, and maybe in childhood, that we believe them to be genetic. But the genetics are not simple genetics. The little red circle there, this is a slide often shown of Ingrid Scheppers and Sam Berkovic's, the powerhouse from Melbourne. That little tiny red circle is where there's an actual identified gene, and the genetics are known, and it might go from one generation to the next. That's rare, and there are some conditions such as tuberous sclerosis and conditions like that that fit inside there. In the rest of the circle, even though we think they're genetic, it's complex genetics, and the genes have not been identified, but whether it's one gene or many genes, or genes and something in the environment, is the question. So the next slide, thanks. So here are some figures, because one of the questions that comes up when you make a diagnosis of epilepsy for families is it genetic? What's the chances the rest of the children will develop epilepsy? And even if we jump down there to the second part, generalised epilepsies, the ones that we often think are genetic, and you've heard the term genetic generalised epilepsy, there's only about a 10% chance that the other children would have epilepsy. So it's not a single gene. It's not for doctors and nurses and others in the audience who understand it's not Mendelian inheritance, or autosomal dominant, or even recessive. So even in those that we think are genetic, the genetics are complex, and the risk to other brothers and sisters is about 10%. Focal epilepsies are less commonly have a genetic point, but I agree entirely with Jamie Gordon that there are probably genetic factors that explain the susceptibility to seizures, so that why two people with the same insult to the brain, one develops epilepsy and one doesn't. Although, of course, that may not be true, but that's a very good theory. Next one, thanks. So we use this mainly. We divide epilepsies up into whether we have generalised seizures or focal seizures. And there is a distinction between the classification of seizures and the classification of epilepsy, but it's always confusing, and it's confusing when I'm talking to just doctors, and I'm sure it's confusing to doctors and people with epilepsy and their families. So I won't make that distinction here. We will think of a focal epilepsy as having focal seizures. We'll think of a generalised epilepsy as having generalised seizures. Now, generalised seizures can be convulsions, such as tonic-clonic seizures or grand mal, but another big group is absence seizures or petit mal seizures. So there are different types. They're all linked by the fact that the seizures, and a gentleman asked a question about this, that rapidly spread from one side to another. And again, a very good point made by Jamie Gordon is that we now think of the brain as a network. Even in the focal epilepsy where they're starting somewhere, they rapidly engage a network that might just be in one side of the brain, but it's certainly not in just one tiny spot. So let's have a look at a classic seizure, this next one here. You probably need to just click on the square. Here we go. So this little girl hyperventilates.
So, mate, you're very good. You keep doing that. That's fantastic. Keep going. Super. You okay? Never breathe for me. You okay?
Stares and swallows.
Okay, Jane, I'm going to ask you now, how are you doing there? Good? Do you remember me giving you a to remember during that? That's alright. You carry on the other thing.
That's a classic petit mal seizure. They are very common in childhood, one of the commonest seizure types, and a common epilepsy. And there's a brief interruption to consciousness, and the technician knew immediately she was having a seizure because he's watching the EEG, and they have this very characteristic spike and wave pattern that was shown to you by Jamie Gordon. Now, that's important for the patients. I mean, that sort of seizure can lead to injury if the patient was to wander out somewhere, but they don't fall with them. They actually rapidly come under control, often with medication, and so the consequences of that seizure are quite different from grand mal seizures. With focal seizures, we are often seeing a reflection of the spot in where the seizures start. So they differ between different types of seizures depending on where they start in the brain. And the big distinction here is whether there's just a warning, an aura, as we heard before, or whether there's a loss of awareness, a loss of consciousness. And this terminology, which hasn't really been replaced, even though there's many attempts to replace it, simple partial seizures or auras is there's no loss of consciousness, and complex partial seizures is when there is some altered awareness and usually amnesia, and of course then risk of injury, and that's one of the great consequences for patients. So next slide. So looking around the brain, frontal lobe seizures tend to have motor activity. They can be posturing or jerking, head and eye turning, the classic seizure that Jamie alluded to that was picked up by the ancients, looking to the heavens. They may also have some unusual sensations and thoughts. And moving on, temporal lobe seizures might evoke memories. They might have taste. Taste is up at the top of the temporal lobe. Sorry, sounds up at the top of the temporal lobe, or taste deep in the temporal lobe near a structure called the insula. And moving on, thanks. The parietal lobes might have sensory changes, or in the dominant hemisphere, we're seeing the right side of the brain here, but in the left side, there might be an interruption to speech. And finally, the occipital lobe, there might be visual hallucinations. So focal seizures for patients may have very different symptoms that are quite specific to where they start. Thanks. So this is a young man. He's having a seizure, watching the left side of his face and watch his left arm. And so it's starting in the back of the frontal lobe, right next to those parts of the brain that move the left side. And our technician will ask him something in a moment.
Put your left arm.
Put your left arm up. So he's having a seizure which might be described as a mini convulsion, but he's not lost awareness. So the seizure's very focal to one part of the brain, and he'll actually respond. You can see his hands still stiff and jerks a bit, but he is responding. The lady who's off camera there, our nurse, is injecting him with an isotope for a SPECT scan. And the next slide, thanks very much. So where the little arrow is there on the picture of the brain, he had you can see it's a bit smudged there, and that was an area of focal cortical dysplasia, exactly. You saw one of those illustrated. And removing that stopped his seizures. They hadn't responded to medicine. So finally, how you might classify is epilepsy syndromes. And here, you're then taking a lot of what we've talked about and putting it into a classification scheme, which I won't illustrate because it is a bit tedious and it's also a bit contentious at the moment. we often divide them into whether there's an underlying abnormality in the brain, whether the seizures are symptomatic of something, and we might then say brain tumour or brain injury, or whether there's nothing abnormal in the brain, and that uses the old term idiopathic, and many of those are ion channel disorders, exactly as Jamie's told us. So epilepsy syndromes are quite valuable because even though, and they fill up that 2/3 of the pie chart that I showed you that was blank and white, that's almost full of epilepsy syndromes, and we can say, oh, this is juvenile absence epilepsy, and that has some very helpful prognostic value and even sometimes tells us about what treatments to use. So epilepsy syndromes describe the patient's illness, and they're very valuable. They use the seizure types, they use the EEG, they use all the different features that we have. Thanks. So when it comes to the patient with epilepsy, the seizures, we try and divide them into focal or generalised, but for the patient themselves and their family, whether consciousness is lost with a seizure has probably the greatest impact, and that has a tremendous impact on restrictions. And whether there are convulsions or not adds another element in terms of potential for injury. Next, thanks. So this is just skip over this. We overlap a little bit in our presentation. The tests that we use are the EEG and the MRI scan. The next one. Next slide, thanks. That's a characteristic EEG finding there. The blue line at the bottom is a run of photic stimulation, and if you provoke that in the EEG, this is an example of the EEG that Jamie didn't show, and get a burst of epileptic spikes, that's photosensitive, and that's a characteristic feature of generalised epilepsy, so we often use this in the diagnosis. And the next slide, thanks. And MRI scans, and here there's a red arrow up the top on your upper right there. Another example of a finding that's occurring in MRI scans now that we never used to see in the past with CAT scans and even early MRIs. And there's a strange folding of the brain there and a very deep cleft in the brain. And that explains that person's epilepsy. Thanks. Now, next one. So who should get anti-epileptic drug treatment? So this comes back to some basics that underlines a little bit of the material that you've already heard from Jamie Gordon. You should start it in people who are going to have recurrent seizures. So you don't start it for a single seizure. You need to look at the risks of seizures. Once you've had 2 seizures, the chances that you'll continue to have seizures is as high as 90%, but generally quoted at about 80%. So it's far too risky not to treat. There are some situations for patients where they may not treat, and you can imagine if they were extremely rare and all they were auras, you might not treat right away. Okay, next. And what we're trying to do is choose a drug, usually one drug, that stops the seizures, and we try and match it to the seizure type, as we'll see in a moment. We want to make the patient seizure-free, not just reduce it. We want to make it seizure-free, but we want to do that without side effects. So I'll add a little bit more to what Jamie said is, and this comes back to the importance of the history. How are you going to know that you've made them seizure-free? There is annoyingly no blood sugar level, no sphygmomanometer to check the blood pressure. There's no measure of the activity of the brain's disorder in between the seizures. Not yet. There maybe are some things that are coming, stimulating the brain with magnetic pulses, may give us a measure of excitability. And we may, in the future, know whether the drugs we're using are now at a point where they're going to stop any future seizures, but we're not there yet. So what we do is we normally look at an interval that's 2 or 3 times the previous separation between seizures. Now, that's pretty easy if they were every week. We don't have to wait long. But if your seizures, and this is very common, and some of you may experience this, are in the early part of the disease once every 3 months, then you're going to have to wait 9 months statistically before you could say there's any success. And you'd be very wary of a doctor that sees you a month after starting treatment and says, wow, fantastic, we're really on the right track here. You've got to watch for proper interval, which is matched to whatever frequency the seizures were occurring at. And that's not so common at the beginning of the treatment of epilepsy, but very common when you're changing a drug. And any neurologist would wrestle with this, or a general practitioner, that if you're changing the drug and you're saying, well, there's been a great success, you've got to match it to how often the seizures were occurring. Next, thanks. Now, this is a complicated slide that I've taken directly from one of the lectures that we give to our trainee doctors, but it gives an illustration of that the drugs are not specifically matched to individual seizure types, except for one drug, Zerontin or ethosuximide, off there to the right. That's matched to absent seizures and not to anything much else. But the other drugs have broader spectra, and they're usually more for focal, and the classic drug carbamazepine and some of the newer ones, in fact most of the newer ones have been developed for focal epilepsy. And then down the bottom are the drugs that have a broader spectrum of both focal and generalised. And we'll try and pick those drugs and use them and according to side effects. So for instance, a young woman in her 20s who might be starting a family, valproate or Epilim or Valpro, even though it may be the best drug for generalised epilepsy, is not at all a good choice for that person. We need to factor that in. Next, thanks. So this is a most important figure. 75% of patients will usually are controlled when they start. Most of them with the first drug they ever have. So something like 2/3 of the patients have control with the first drug they ever have. So overall, the prognosis for control with epilepsy is very good. And if you look at clinic studies over many years, you can achieve a 5-year remission often in 75% of people if you work at it. Next, thanks. The most important predictor of whether you will achieve that control is actually the response to the first drug, interestingly. They look at all sorts of different things, and whether they're underlying tumours, whether they're underlying intellectual handicap, all of these factors. It was the frequency of the seizures and how quickly they came under control. Now, neurologists are often looking at that 25% of people that when they're not well controlled, and that's a much more difficult group that we'll come to. Next thing. So tips for improving drug tolerability. Always try for a single drug. Always introduce drugs very slowly. Always tell people about the drug, what the side effects are. It's very foolish not to tell people about them. Everyone reads about it on the internet, and you may be able to anticipate something that they might experience and give them some comfort that that's a transient thing. And if they're not well tolerated, you should look at another drug, and you should be changing if they're not effective. Thanks. Next, thanks. So what are some of the adverse effects? Now, we've heard about a couple of them. I'll just characterise them here as acute dose-related side effects, and these are lasting there for a few days. And if you introduce drugs slowly, now we don't always have the luxury of being able to do that. This happens less often, but if you introduce them rapidly, this is common. There's sedation, nausea, unsteadiness. Then there are the problems that develop in the next few weeks, and the big one there is a rash, a hypersensitivity reaction. And overall, with the older drugs, that's as high as 5%. And then the long-term ones relate to weight, bone health, and perhaps effects in pregnancy. So next, thanks. Bone health is a tricky area. So I commonly get asked by patients when I've established that they will need to stay on their medication, and this is something we might establish in the first year of treating someone, maybe after an attempt at withdrawing it or just knowing the nature of the disorder, they'll always say, but what about my liver and my kidneys? And interestingly, these drugs don't really have any bad effects on the liver or the kidneys. They're happy to churn away at getting rid of the drugs for the rest of your life. Maybe Topamax might occasionally cause renal stones. But one of the things they all seem to do, and it hasn't been a drug that doesn't do it, is reduce your bone mass. Now, that's worse if you're starting it off in adolescence when you're accumulating your bone mass, and we haven't figured out the best thing to do here, nor have we figured out the mechanism. Even though everyone's put on vitamin D, it doesn't seem to be osteomalacia, which is a loss of vitamin D or interruption to its metabolism or absorption. It doesn't seem to be simply a problem with calcium, laying down calcium, and it's probably an effect that the drugs have on the cells that remodel the bone. And I'm not sure how we're going to deal with that. But bone health is really important. And the important thing is exercise, weight-bearing exercise, and in fact not being too thin, which brings us to our next slide. There's obviously great variations in how people see their weight, and you can see some lovely examples there in the cartoon. People that are perfectly normal weight or what is really a healthy weight are worried about it and try and lose weight, and then some of us, especially males, as they get older, don't seem to have any concept of how overweight they've become. But weight is a big issue with a number of the drugs, and my list probably not entirely. I've used the brand names here, not to disparage any companies, but just they're more recognisable for many of you. Valparate is a big issue for weight gain, but it does occur with Tegretol, and it certainly occurs with Fycompa. Next one, thanks. Now, pregnancy outcome. This is an important thing, that 2% of all pregnancies have some problem for the baby. That's in all women. And the drugs do increase that overall to about 2 or 3 times, or 4 to 6%. But the important number is 95% of the pregnancies are going to be normal. And that's the thing you really should stress amongst families who are facing having babies on the drugs. It's most likely the baby will be perfectly normal. But there are some areas where still it's more likely the baby will be normal, even if you use valparate, but it's getting up to a level where you'd always avoid it if you possibly could. So you plan pregnancies. Thanks. Now, safety and seizures. This is heading into my last points here. The workplace machinery, swimming, heights, working at heights, driving. These are big issues for patients with epilepsy if it's not controlled. And even in the early days of the diagnosis, before you know exactly how it's going to be controlled, this is a big issue. So next one, thanks. So this is a study done some time ago now, but getting on to 20 years ago, and it looked at what are the concerns of people living with epilepsy, and driving right up there at the top. But you can see some of the things I flagged in the early part of the talk: independence, work, embarrassment, stigma, if you like, dependence on others, dependence on medication, and stress. Okay, let's have a look at driving. Now, we follow these standards, and a lot of work, and I think Jamie, in fact, has been very involved in that, and Simon Hammond has been involved in developing these guidelines, because nobody faces this issue more than the rural population. I go down to Wagga Wagga 2 days a month and see just people with epilepsy, and I was surprised at how enthusiastic the neurologist down there was for me to come. And then I realised at the end of telling 5 people in one day they couldn't drive anymore, what a relief it was to him to have me come and do that for him. So next one. Now, how do you work out who's at risk? Now, if you look at all, and there's some lovely insurance data, and I won't go through this, these are slides from Ernie Somerville, who is the chair of our driving committee for the neurologists, and has done an enormous amount of work with others on this. If you look at all people on the roads, there's a risk of about 1 or 2% a year of having a severe accident. That's for anyone. That's based on insurance data. That is definitely higher for people with epilepsy if they're driving and their epilepsy is active. Now, we need to look at a risk that's less than twice the risk, so less than 2%. So how are we going to calculate this? Next slide, thanks. So if you look at people with a chance of one seizure a year, and you work out, and these are for private drivers, they might spend about an hour and a half on the road. This wouldn't be entirely true in the rural areas, but in the city, an hour and a half on the road a day. Then you can work out there's about a 3% chance that they will have a car crash related to a seizure. Now, an acceptable risk is about 1% a year, similar to the base of the general community. So that translates into a chance of seizures in the next 12 months of 33%. And that's usually well-controlled epilepsy. It's not zero. Next slide, please. So if we are going to predict that someone's going to have that less than 33% chance of a seizure in the next year, statistically it's been shown that being 12 months seizure-free will predict that. So that's the default. Everyone should be 12 months seizure-free on their medication. Now, there are discounts, though, for single seizures and starting therapy for the first time. Next slide, thanks. And these are really important. So if you've only ever had one seizure, you don't know if you've got epilepsy. So you don't need to wait 12 months to get down to that figure of less than 33% chance of a seizure in the next year. 6 months will do that. And similarly, if you had a seizure that's been provoked by something, say a blow to the head in some medication changes, some other surgery, then you only need to wait 6 months. If you're starting treatment for the first time, you only need to wait 6 months before you can go back to driving. And then there are some very important categories that quite a few people with epilepsy fall into. Sleep-only seizures. So this is not uncommon where the seizures are only ever during sleep. And this might be the case with some of the frontal lobe epilepsies, or it might evolve with treatment that they're that well controlled, they never ever occur during the day and they rarely occur at night. And so those people, and I have many patients like that drive without any problem. You've got to watch that for at least 2 years though. And then safe seizures. So if you're just getting auras, just getting a feeling, and it's not going any further, and often the medication will stop the seizures spreading in the brain, but not stop them starting. And if that's been observed for a few years, and you can find family members that can confirm that they're not confused, you can drive. Unfortunately, if you have an accident caused by a seizure, and I think this is one of the tricky things for the patient, this occurs for the first time when someone's diagnosed. They actually come to attention because they have an accident. You're banned for 12 months, and it's very difficult to argue otherwise, even if you then start treatment. Next slide, please. So I think we'll keep going. Next slide. So what are some of the other things that face patients and people with epilepsy and their families? There's risk of injury, falls, facial laceration, burns, and unfortunately things like drowning. They're much more common than the next thing that everyone fears nowadays, and this is this phenomenon of sudden, unexpected death in epilepsy patients, or SUDEP. Now, in a well-controlled group of people with epilepsy, it's very rare. It's 1 in 1,000. And it's a strange thing that occurs where people most commonly, when it's been documented, and there are literally tens of cases, not at all hundreds of cases that have been studied in detail, because when there's been a recording going on at the time that it happened, the patients seem to have a seizure which looks pretty much like their other seizures, but they just don't wake up from it. They get a sort of electrical shutdown of the brain, they stop breathing, and then their heart stops beating. So it's a very rare disorder, but it is absolutely devastating when it occurs. Next slide, please. So the last point I'll make, and I'll skip through this a bit because Jamie Gordon's covered the issue of surgery in epilepsy. What if you've got that 25% where the seizures are not well controlled? And I would imagine that many people here will be struggling with that themselves or struggling with that within their family. And this is tricky. Often you're on multiple medications, there are tremendous restrictions, and you may be suffering from those medications. And it's well worth seeing a neurologist who's got an interest in epilepsy to try and look at whether the medications can be manipulated. You might not get any improvement in seizure frequency, but you might be able to reduce the medicines down so you're feeling much, much better. You might be able to change the seizure frequency by just trying new combinations. And in clinics attached to hospitals where there are big groups of people being treated for refractory epilepsy, if you keep working at it, 20% of any group of those patients will become seizure-free for 12 months if you just keep working at it. So it's not something to give up on. Unfortunately, the risk of things like SUDEP goes up in this population to much more than 1 in 1,000. Next. So these are the three things that we would do in our epilepsy centres, and Jamie's alluded to the value of referrals to comprehensive epilepsy centres. They're not much different than, in terms of the opinions, you're not going to get much different from seeing Simon or other neurologists up here or Jamie, but we often have access to recording and prolonged recording and maybe some different imaging things that will allow us to look at the diagnosis again. So the first thing you would do is review the diagnosis. You would review the medical therapy, and then you would consider things like epilepsy surgery as alternatives to medical therapy. And in reviewing the diagnosis, it's remarkable that 20% of the people that we see with uncontrolled seizures are actually having non-epileptic seizures, most commonly psychogenic seizures related to anxiety that may have been going on for years, and they obviously need different form of treatment. Changing the medication can help, as I've just said, and surgery is a very valuable option for medically refractory epilepsy. Moving on, thanks. Next one. So you've got to show that you can define where the seizures are coming from. They've got to be coming from one spot, and you've got to know that operating on that spot is not going to harm the patient at all. So next slide. The commonest is temporal lobectomy, just to give you some figures to back up what Jamie was telling us. That's about 60 to 70% seizure freedom after a temporal lobectomy. And in the outside the temporal lobe, it's not at all as good. And that's really important to keep in mind. And I've been such an enthusiast of epilepsy surgery for 25 years, and it's really been tempered over the years, and I would be very cautious always now. I always say to people, have the assessment and see what we find, but I think you really need to be very upfront about the chances of seizure freedom with some of the complicated frontal lobe epilepsies. Next. I think we'll just move on. Next, thanks. Next. So, I'll wind up there. I hope I haven't gone on a bit too long. We think of seizures versus epilepsy. We try and classify seizures, and we largely do it as partial or focal versus generalised. We'd love to know the causes of epilepsy, but it hasn't yet been the case that we can tell everyone the cause of their epilepsy. And we tend to treat their seizures. Maybe we should be treating the whole person more often, but we generally follow their seizures, and we do that very much on the history. And for patients with epilepsy, one of the great implications of living with it is the issues of safety and each individual seizure and its impact. Thanks very much.
We've only got time for a couple of questions if anyone's got any from Dr. Blaisdell.
Talking that 1% of the population has epilepsy. Does that figure hold true to every country in the world, like Norway, do they 1%, is Japan 1%?
Yeah, that's interesting. It does, yes, all around the world. Interestingly, Japan has a very high incidence of febrile convulsions, something like 10% of kids, as high as that may get that. But then that's not epilepsy, they're just single seizures usually. So that's a good question. No. And look, you know, I went to we all in Australia take our hats off to the group in Melbourne and put epilepsy genetics on the stage. I remember vividly going to lectures in 1995 when that gene that Jamie referred to, that they discovered, and they said, in 2015, you will go to the doctor, there'll be no EEGs, there'll be no MRI scans or anything. You'll have a blood test and it will tell you the type of epilepsy you have, what drug you're going to respond to, and whether you're at risk of drug side effects. And all of those things are still research projects that never came off. So where it's useful to do a gene chest, and not one gene, but a panel of genes, is, say, in a child, and again, Jamie's alluded to this, say, with something like Dravet syndrome, one of those dreadful childhood epileptic encephalopathies, and that does yield results. But for the rest of us, that doesn't. Yeah. Yeah, well, there are definitely families with it, but even in those families, if you go looking, because it's quite straightforward now to look through the whole genome, they haven't found a gene. So you do see that in some families. So if you take that group of epilepsy, a grand mal type of seizure, about 30 to 40% of family members will have that. And so that's going right out to cousins and uncles and aunts. But there are certainly families where the next generation have it.
I'm just wondering, what kind of causes when someone's been on medication fairly successfully, like a seizure for say 3 years or so, and then just stops working? Why does that happen? And how common is that?
Well, now I would say to you, and I've got to be very careful here because I'm speaking to people with epilepsy and their families, having a seizure every 3 months isn't well controlled. So it's a relative thing. You say it goes out of control, but maybe it just occurs twice as often. But it's not well controlled. Yeah. Well, the thing, there's not always a good explanation. There's a couple of possibilities. One is the phenomenon of clustering, and the paediatric neurologists wrestle with this all the time, that things seem to be going on smoothly over months, and then there's this dreadful eruption over a week, and it hasn't been explained. So clustering of seizures. The other possibility is that something is going on, and you need to reassess the epilepsy. Yeah. And there are factors that impact on the seizure control. Stress is one thing that we doctors tend to discount, but I think patients and families with people with epilepsy feel that stress is a factor. And certainly depression is an important thing that can worsen the control of seizure. Thanks.
Okay, thank you, Dr. Blaisdell. Now, we might just quickly go back to that video that for Cameron that we started watching that stopped, and then that will conclude the day. While I've got everyone's attention, just thank you very much for attending today. I would like to thank all our speakers who have given us their wonderful insight and knowledge into epilepsy. And I want to take this opportunity to also thank my staff, Joe up the back, Raylan and Tracy over here, for the help that they've done to help me get today organised. So thank you very much, everybody. And don't forget to fill out your surveys on your way out, please. Thank you, everyone, for coming.
Just want everybody to thank Beck and the staff for wonderful work.